Welcome, IBD Gecko session. These sessions are hosted by the Gastro Foundation of South Africa in association with Project iEcho based at the University of New Mexico. Of course, you are here because you know that the sessions are on Wednesdays, but for those who may be new, these sessions are held weekly on a Wednesday, and the IBD sessions probably happen every 5 to 6 weeks. We want this session to be interactive, so please feel free to post your chat in the question box, or better still, to put your hand up so that you can ask a question. So we've got two presentations for you today. The first is going to be done by Professor Watermeyer, who absolutely needs no introduction. She's going to take us through a case of complicated Crohn's disease. Jill, over to you. We look forward to your...
I'm just going to share my screen. All right, can you see my slides?
Yes, we can. Thanks, Jill.
Okay, well, thanks very much. So I'm going to present another case of complicated Crohn's disease. So this is Mrs. L.O. She's a 71-year-old woman. She's a pensioner. She's been divorced for many years. She has 4 children and quite a few grandchildren, and she lives in Tableview here in Cape Town. She's an ex-smoker. She stopped smoking at the age of 25. No really significant past medical history, except for breast implants, which were removed in 1999, and incidental gallstones on ultrasound. She has no family history of any note. She was diagnosed with Crohn's disease way back in 1986. It involved her terminal ileum and her cecum with a normal colon, and it was very much a stricturing phenotype with the Montreal classification of A2, L1, B2. Her Crohn's was complicated by iron deficiency anemia, as well as vitamin B12 deficiency and osteopenia. Very shortly after she was diagnosed, she presented with a subacute small bowel obstruction due to a terminal ileal stricture, and she underwent a resection of her TI and her cecum with a primary anastomosis. She was not started on any treatment post-operatively. And she was 100% well for 16 years, and this is often the case with this particular clinical picture, early onset, short segment, terminal ileal cecal disease, where surgery is an excellent first-line therapeutic choice. In 2002, she presented again with recurrence of her Crohn's disease, almost exactly the same phenotype as her original presentation, a near-terminal ileal stricture and small bowel obstruction, and at this time she had her second near-terminal ileal resection, again with a primary anastomosis. This time, she was started on azathioprine post-op, given that it was her second surgery. Shortly thereafter, she developed a melanoma of her right shoulder, which was fully excised, and the decision was made to stop azathioprine in view of the melanoma and to just watch and wait. And then she actually was lost to follow-up. In 2011, she represented with the same story after not having been seen for many years. Again, a subacute small bowel obstruction with active near-terminal ileal Crohn's disease and a stricture. And she underwent her third resection, again, of the near-terminal ileum and of the right colon. This time, she was commenced on methotrexate post-operatively. And she actually did well. Her Crohn's disease went into remission. But a couple of years later, she was noted to have a raised alkaline phosphatase and gamma-GT, and an ultrasound was done, which showed a fatty liver. She went on to have a liver biopsy, which showed steatohepatitis with bridging fibrosis. So we consulted our liver colleagues who strongly advised us to stop the methotrexate permanently. So she was really just on vitamin B12, folate, and vitamin D and calcium supplementation. 2018, she presented with 1 month of severe diarrhea and cramps. And at that point, she was diagnosed with Clostridium difficile on stool microscopy, culture, and toxin. And she was admitted, she was treated with metronidazole, and we added some cholestyramine for possible bile salt diarrhea. And she did very well. She responded, and her symptoms resolved within a week of antibiotic therapy. And given that she was 100% asymptomatic, she was really not keen for any other investigations or for any other treatment. And essentially, she then went off the radar again. In September of last year, she presented with 3 weeks of severe cramps, diarrhea, and loss of weight. At this point, she'd been on no immunomodulators for 3 years. Colonoscopy was done, which showed severe post-operative recurrence of the Crohn's disease with a near-terminal ileal root score of I4, which is about as bad as it can get, at the anastomotic site and in the near-terminal ileum, with 15 centimeters of distal small bowel involvement. Again, her colon was entirely normal. This was her MRE, which shows a markedly thickened, active-looking near-terminal ileal inflammation with some upstream dilatation of the bowel, suggesting some degree of obstruction. Her full blood count at that point showed a white cell count of 5.4, a normal hemoglobin of 12.3, a normal MCV, as well as a normal platelet count. Renal functions were normal, as were her liver functions, with the exception of an elevated alkaline phosphatase in keeping with her steatohepatitis. She had a fecal calprotectin performed, which was 279, which is obviously above what would be considered an acceptable level and suggestive of active inflammation. The CURP was 36. The serum iron and percentage saturations were a little on the low side. Her ferritin was 42, which is also pretty low given that she has active inflammation and a CRP of 36, and one would expect it to be much higher. So there's definitely an element of iron deficiency, even though her hemoglobin is normal. Her vitamin B12 was in the normal range. Her serum folate was elevated. The thyroid TSH was normal, and her chest X-ray was clear. So what next? Well, she'd already had 3 surgeries, so really a 4th one was felt to be a last option. She was not happy to take the azathioprine given the previous melanoma, and she can't take methotrexate because she has got fibrosis on liver biopsy. So she needs a biologic, but what? Well, delving a little deeper, during all the times that she had sort of not been really attending hospital, she had had a recurrence of her melanoma, this time on her right breast in 2019. Again, this was fully excised. But anti-TNFs were relatively contraindicated, or at least at that time, because there had been an increased safety signal for melanoma with this particular biologic. And this stemmed largely from a health insurance claims database study published in 2012, which used data from over 10,000 IBD patients, each matched with 4 controls. And anti-TNFs were associated with significant increase in the risk of melanoma, with an odds ratio of 1.88 for the overall IBD population. But this was particularly in Crohn's disease, with an odds ratio of 1.94, but not really a problem with ulcerative colitis. So the decision was made to start her on vedolizumab, given that it's gut-specific biologic. It has a very good safety profile and is probably one of the best recommended agents in patients who've had a previous malignancy. Shortly after her first dose, she developed a squamous carcinoma of her left hand. But this was thought not to be related to vedolizumab at all, so the decision was made to continue with vedolizumab. Unfortunately, there's been no follow-up since February, so I really hope she hasn't disappeared off the radar again. So that's rather a simple case, just highlighting the complexities of using our various new agents in patients who have a previous malignancy, and Mashiko is going to take us through this in a little bit more detail. Thank you.
Thanks, Jill. That's a nice case, I think, which demonstrates a couple of things in the management of patients with IBD, who can be a little bit difficult with the complications, particularly cancerous complications. Are there any questions from the people online? I don't see anything yet posted in the chat, but please feel free to.
I think Chris has got his hand up.
Yes.
Very nice, Jill. So, I mean, clearly anti-TNFs we would be concerned about. So the thought process, I'm sure, was Stelara versus Avedo. I mean, would you have considered Stelara as a better choice with regard to Crohn's?
Yes, most definitely, but it's, as you know, much more expensive than vedolizumab. So we were very, very lucky to get Vedo.
Okay, so putting costs aside and affordability and accessibility, just on evidence, you would have gone for Stelara.
Most definitely. My personal preference is that it is probably better in Crohn's disease than vedolizumab.
Yeah. Jill, I have 2 questions. The first being, I can't remember when methotrexate, metronidazole was introduced as therapy to prevent post-recurrence. And I see that in all those times that she had her surgery with primary anastomosis, there's no mention of metronidazole. Was it not given, or?
No, Masha, it wasn't really done back then at all, I must say. It's only become sort of common practice in the last 5 or 6 years. So back then, I don't think we even really considered it, to be honest.
Yeah. I mean, that may have helped actually in reducing her risk of recurrent TI disease. I mean, other than the fact that she was not compliant and disappearing from service. Was she a smoker as well?
No, she stopped at the age of 25. So that was one good thing in her favor.
Okay. And then the final question is that the risk of melanoma with thiopurines, because it's not really noted to say, it's the other skin cancer. So what do you know of that?
So, yeah, I mean, I think, as a thyroid, everybody was a little bit nervous of it with a malignancy. And melanoma is a very tricky malignancy, as we know. It has this nasty habit of cropping up again years later, and obviously very difficult to treat. In those days, there were not immune checkpoint inhibitors available. So, I don't think it was the wrong decision at all to stop azathioprine, given that there was fairly limited evidence at the time. But you're absolutely right. Melanoma is not the skin cancer that is a problem with azathioprine. It is basal and squamous cell carcinomas.
Yeah, but I think also it was the right decision in view of the age. One would be concerned about other cancers with azathioprine.
Absolutely. Absolutely. Mash, I see there are 2 questions in the chat.
2 questions, yeah. So does oral methotrexate work as well as subcutaneous? Hello, Sianda.
Yeah, it's a very good question, and there isn't a correct answer to it. So the reason that subcutaneous methotrexate was the sort of treatment of choice was because of the possibility of malabsorption in small bowel Crohn's disease. But, I think if somebody's got relatively normal proximal small bowel, I don't see why oral methotrexate should really be much of a difference. And certainly it's much easier to come by than the subcutaneous formulation.
Yeah, and it works for Crohn's, we know that. And then Kinfe Waldu, I'm not sure where you're based, but your question is, any specific benefit of methotrexate over AZA? I think Jill has just answered that. And then why not biologics started before switching to methotrexate?
Because back then we hardly had any access to biologics at all. And basically in state practice, we are forced to cycle through the immunomodulators before considering a biologic.
Yeah. And as you correctly pointed out with that study, that earlier study, then in this case, with the melanoma, then biologic would have been a contraindication, at least at the time.
Yeah.
Kinfe, if you don't mind, please post in the chat where you're practicing, because I think your name is not South African and I'm just a curious bugger. Any other questions, fellows?
Mash, I think the question that he also asked was there any specific benefit of methotrexate over azathioprine? They've obviously not really ever been studied in a head-to-head fashion, but the choice would depend on the individual patient. So, for example, if they had an extraintestinal manifestation such as arthritis, then methotrexate would probably be a pretty good choice. If they'd had previous azathioprine-induced pancreatitis or neutropenia, then methotrexate would be a better choice. I think it really depends on the particular patient profile.
Yeah, and I will cover it a little bit, but in terms of having to choose, especially for combination therapy, methotrexate over azathioprine, methotrexate has a slightly better carcinogenic profile. So in that case, then you'd rather go methotrexate than aza. Oh, thank you for saying that you are from Ethiopia. Welcome on the platform. Any other questions before I go to my presentation? Jill, are you happy for me to start sharing?
I'm happy for you to start, Mash, so go for it.
Okay, great, thank you. All right. Good afternoon, everybody. Thank you for giving me the platform to discuss this very important topic. And what we wanted to discuss today in the context of the case presented by Professor Watermeyer was how you practically manage a patient with IBD who either has a previous or current malignancy. This is a very important topic, causing a lot of consternation for physicians as well as for patients. So by way of introduction, we all know that the prevalence of IBD is increasing. We've covered this many times on this platform and also in the IBD interest group meetings, where we know that in countries that are newly industrialized, the IBD incidence is increasing because of lifestyle factors. And also our ability to diagnose and treat IBD is improving. So people are living longer with IBD. We are diagnosing elderly people with IBD. Our surveillance programs allow for patients to live longer. And also we are instituting more aggressive therapies earlier on. And all of these factors contribute to patients with IBD living longer. And we also know that as you age, your risk of cancers, intestinal and extraintestinal, also increases. But also on the malignancy sphere, treatments have improved, prognosis has improved. So even patients with malignancy tend to live longer. We also know that IBD on its own is a risk factor, not just for intestinal tumors, but also for extraintestinal disease, but also the treatment for IBDs, either through direct or indirect mechanisms, are also established risk factors for cancer. So then you can understand that it's not surprising that more and more as gastroenterologists, we are going to be managing patients with IBD who either have a previous history of cancer, who actually come with you with the current malignancy, or who develop malignancy during the course of their treatment for IBD. So as I've alluded to, the management is really complex because clinicians may be reluctant to put patients on the best therapy because of concern for initiating a recurrence of cancer. This also might mean that they deny patients the correct therapies for their IBD. We also know that in most of the clinical trials, a cancer or prior cancer might be an exclusion criteria for being included in the trials. If you make it into the trials and you develop a cancer during the study, you will be withdrawn from the study. And also in real world studies, clinicians, again, may have a bias towards undertreating patients with cancer. And so all of these factors make it very difficult for us to be able to get reliable data on the risk of cancer in patients who have IBD, on the risk of recurrence. And so this does make management of these patients rather difficult. So you remember that in 2021, I actually reviewed this topic. At that time, it was based on the iEcho guidelines that were released in 2015. And here they went through basically 4 sections. And we talked about a lot of them, so I'm not going to repeat those in today's talk. But we also talked about the management of IBD in patients with a history of malignancy. And in that guideline, the recommendations were that in patients on thiopurines, calcineurin inhibitors, and anti-TNFs, these should be stopped until the cancer therapy is completed. And the suggestion in that guideline was that you should stop therapy for 2 to 5 years, depending on the type of cancer that you're dealing with, before restarting those treatments in patients with IBD. So we will see whether the guidelines have actually changed in the current iteration of the guidelines. So in the current guideline, this was published in December last year. So please have a look at it if you haven't done so already. They have kind of simplified the guideline. They do still talk about IBD itself as a risk factor for malignancy. And then, of course, they talk about the very important topic of IBD therapies as a risk for malignancy. I'm not going to talk about that. As I said, we've covered this before. And then today, we're just going to mainly focus on treating patients with IBD with either a history of cancer or a current active malignancy. The guideline doesn't distinguish between cancer and malignancy. So I've chosen to use the word malignancy, meaning neoplastic or non-benign cancers. So just to highlight the issue of IBD as a risk, as well as IBD therapy as a risk, this is covered very nicely in the guideline, but I wanted to also alert you to the most recent Red Journal, SAGE's Red Journal, where Innocent has very nicely done an update and a very concise summary on management of IBD-associated colorectal cancer. And then actually in the same issue, our colleagues from Tygerberg have also done a case report of a patient with non-melanoma skin cancer on thiopurines. So again, highlighting the importance of these topics and the fact that we're going to be seeing more and more of these patients, and we really need to be au fait with the best management for these patients. So once again, this you can find on the SAGE's website under the tab Journals. If you haven't seen it yet, it's worth a read, and there are some other lovely articles that have been written by our colleagues. So the only thing I'm going to do in terms of reviewing malignancies related to IBD is in this slide. I'll try to summarize the risk of drug-related therapy with malignancy. And we know that thiopurines are associated with a 5 times risk of lymphoma. Patients also have an increased risk of leukemia, although it's less. I couldn't find any paper that gives the degree of risk. And then we know that thiopurines predisposed to non-melanoma skin cancer. The risk is increased twofold, and then also cervical cancer. And as we just said with Joe's presentation, that melanoma really doesn't flag as a signal for thiopurines. You always have to consider other factors. EBV exposure is quite important, obviously age and then gender. For cervical cancer, this unfortunately has not been demonstrated in all cohorts in IBD. In terms of methotrexate, the risk really is for non-melanoma skin cancer, but again, this was not found in all cohorts. In terms of the anti-TNFs, we know that there's an increased risk of lymphoma. Again, the data is not consistent, and it's certainly not in all cohorts in IBD. And in the data, in the last 5 years or so, there was a paper that Jill showed on the risk of melanoma increased with the use of anti-TNFs. Then there was a subsequent paper, which was a registry, which actually did not show the same risk of melanoma in patients with anti-TNFs. And then a subsequent systematic review did not show an increased risk of melanoma with the use of anti-TNFs. The problem with that meta-analysis is that it was done in 2014. So I couldn't find any data, any recent data on melanoma with the use of anti-TNFs. But overall, the literature seems to suggest that that risk of melanoma may have been overstated in that old data. So the jury is probably still a little bit out there, but it seems that perhaps not as much as we thought a few years ago. Of course, don't forget that if you combine anti-TNFs with thiopurines, the risk of hepatosplenic T-cell lymphoma is high. This is when compared to patients who are unexposed or patients who are on immunotherapy. The good news really is that although there's limited duration of follow-up in patients with IBD, there doesn't seem to be any worrying signals for cancer with the use of vedolizumab and ustekinumab. A lot of this data comes from the non-IBD cohorts, so patients with rheumatoid arthritis, psoriasis, etc. But in IBD, we just need time, and it will be interesting to see what the data will show and what the guidelines will say in the next 5 years or so when we have more experience with these agents. In terms of the JAK inhibitors, again, no concerning signals, although the guideline says that really is no data in IBD. So early signs seem to suggest that there's no concern. The sphingosine 1-phosphate inhibitors, these were not stated actually in this particular guideline, but I found another paper that said that there seems again to be no risk of cancer with the use of these agents. But I suspect that the story is the same, that it's really too early to tell, and we just have to watch the space. So coming to the crux of the talk today, how do you manage patients with IBD with a past or current malignancy? I think it's important to remember that in any event, patients with IBD with a past history of cancer, malignancy, do have an increased risk of incident malignancy. This is when compared to the general population. And this is independent of therapies for IBD. So you can anticipate that if you add therapies for IBD, then the risk is probably increased even more in a synergistic manner. Although there aren't data that can neatly sort of tease these two things out. And I think that's where the complexity comes, the contribution of inflammation and IBD versus the contribution of the IBD therapies. But nonetheless, we know that these patients, compared to the general population, do tend to have an increased risk of cancers. So you have to consider several things. The first of them being the effect of IBD therapy on cancer progression and recurrence. And this is one of the real questions that bother both gastroenterologists as well as oncologists when they're faced with patients like this. So I've taken this data from a paper published in 2019, where they tried to sort of put together in one slide the risk of recurrence of cancer related to IBD drug therapy. And you can see very nicely here that if you look at all those cancers listed there in the top column, basically mesalazine is quite safe. No risk of recurrence for cancer. So one can safely use that. Steroids, no risk, and very, very low risk for non-melanoma skin cancer. Probably not concerning. We use them for induction for short periods of time. So overall, quite safe to use if you need to use them for induction. The thiopurines, they have a potential risk in all of these cancers, lymphoma. Here they say melanoma, and then cervical cancer, lung, etc. And then we know that the biggest risk really is that of a non-melanoma skin cancer. I've shown you the data that it's probably about 2 times. Methotrexate, you can see based on the colors, has a very safe signal. It may be a potential risk with lung cancer and breast, but generally quite safe to use. The anti-TNFs, this is a paper from 2019. Here they were flagging melanoma based on those 3 papers that we've spoken about. Maybe not so much now, but no risk in terms of the solid organ tumor, so lung, breast, and urine. And then safety signal all around for Vido, and Tofa, although really, as I said, we really don't have much data. So this is something to keep in mind in terms of managing a patient. So that's the first thing, the risk of recurrence. The second thing to consider is whether the risk of recurrence is high, intermediate, or low. We don't have any data from the IBD cohorts. This data is taken from patients with the kidney transplant. And so it's sort of an extrapolation, although we know that sometimes the patients with IBD actually do behave slightly differently than the patients with the kidney transplant, mainly because the patients with kidney transplant tend to be on combination therapies. Whereas in the IBD sphere, we are not really there yet with combination therapies, except maybe for anti-TNFs with the thiopurine for immunogenicity. But in any event, just to keep this in the back of our minds, that really the cancers that have high risk of recurrence would be melanoma and non-melanoma skin cancer, bladder, myeloma, lung cancer. Whereas those that have a low chance of recurrence would be things like lymphoma, cervical cancer, thyroid, and then intermediate risk is uterus, colonic, and prostate. So you also have to keep in mind the likely risk of the cancer recurring depending on the cancer type in a patient that you are treating. So in the patient that was presented, there was certainly concern. You would have to adjust your medication in a patient who has melanoma. I think it would be very hard to push on with whatever therapies that she was on without being concerned for recurrence of the melanoma, which, as we know, can have quite a devastating prognosis. So other than the risk of recurrence and the cancer type, the second thing that you have to take into consideration is the effect of chemotherapy on the IBD course itself. So we know that IBD itself can be aggravated by hormonal therapy, and the data is about a 2-fold increased risk, and also checkpoint inhibitors. And the mean duration after the start of checkpoint inhibitors is about 7 weeks before the patient presents with worsening IBD. But in the last guideline that I did, they had suggested that radiation also increases the risk of IBD flare, but actually in the recent guideline, this is now disputed. So radiation and chemotherapy do not increase the risk of a flare of IBD. And really the best predictor for activity is activity of the disease in the preceding year before therapy was started. And really what they suggest that we do is that you need to be aware of this. You need to monitor quite carefully for flares and treat them. Don't forget that patients on chemotherapy can have diarrhea as a side effect of the medication. We know about checkpoint inhibitor colitis. Patients, of course, are immunosuppressed, so they could have opportunistic infections, and it could just be the flare. So you would investigate the patient as you would any patient with a flare, excluding opportunistic infections and other potential causes for the diarrhea. And then you also have to keep in mind the recent control and current control of the patient's IBD, the risk of a flare, again, depending perhaps on the phenotype of the disease, etc., the history of the patient. You have to consider alternative treatment options. And I think it's very, very important, and this is highlighted more in this guideline than the 2015 one, is that you really have to consider the patient's preference, their perceptions are quite important, and really their acceptance of risk of recurrence of cancer. So this is really a discussion to be had between the doctor and the patient so that there is collaborative management of this situation. And then, of course, you have to consider, other than this IBD-specific risk factors, the usual traditional risk factors for cancer. So patients who are still smoking, obese patients with colorectal cancer, alcohol in some cases, etc. So those risk factors also have to be managed, because obviously if the patient persists with those, they may readily have another recurrence or a new cancer on the basis of these risk factors, not necessarily the IBD or the treatment for IBD. So it's a whole comprehensive management of a patient, and really addressing all the risk factors to try and reduce that risk. So what do the guidelines say about the use of thiopurines in patients with either past or current malignancy? Note that there's 100% consensus, and basically with respect to past malignancy, they say that observational data in patients with IBD is limited and skewed. The data is difficult to interpret. The studies are heterogeneous. Some of the studies look at overall cancer risk, and others are trying to subgroup it into specific cancer subtypes, which is also very difficult if you're dealing with relatively small numbers. So, but overall, if you look at the data, there seems to be no additional risk of incident malignancy with thiopurine use in IBD in patients with a past history. And so the recommendation is that they can be initiated with caution and after considering the risks. And of course, ongoing screening of patients, and then prevention of particularly skin cancers. That advice needs to be given to patients. And I think in our daily clinical practice, we probably don't do that enough in a country like ours, where we've got so much sunlight. I think we don't stress enough the preventative factors for patients who are on thiopurines. And then what about patients with current malignancy? So here there is a caution that is thrown, and they say that you should preferably withdraw the thiopurines in patients with current cancer. And they say until the cancer is under control. The problem with the guideline is it doesn't define what under control means. In the previous guideline, they had said 2 to 5 years. In this guideline, they don't mention any time period at all. The only thing that they do say is that in patients who've got a non-aggressive basal cell cancer or preneoplastic lesions of the cervix that have been dealt with, you can continue thiopurine therapy with close monitoring. So it's still an open question as to how long do you withdraw the thiopurines for once a patient has got a current cancer, not addressed in this particular guideline. What about methotrexate? Again, you can see that the consensus is 100%. So in patients who've had cancer before or who have cancer now, there's limited data. And most of the studies compare methotrexate with thiopurines, anti-TNFs or VIDO, not placebo. And then there's heterogeneous data from both IBD and non-IBD cohorts. So the guideline only says that at this point, there's insufficient data to make recommendations. In the studies that have been quoted in the guideline, they do say that due to a slightly better profile in terms of cancer, that methotrexate are slightly better, is slightly better than the thiopurines. And this is really in the situation where you have to use a combination therapy. So that's what they say. But in general terms, they say the data is limited and they are unable to make any specific recommendations. And I suspect that it's going to be difficult over time to get data that is sufficient, because I could be wrong, but my inkling is that we use methotrexate not as much as we do azathioprine and 6-MP, and certainly not the other drugs. So I don't know if there would be a study which can definitively answer this particular question. And then anti-TNFs. So what about their use in patients with past or current malignancy? Again, 100% consensus, which is really difficult in these recommendations where you have multiple people. In this recommendation, they had 34 experts. So for them to agree with 100% consensus is quite impressive. And really reviewing the data, they show that new or recurrent cancer incidence did not differ significantly in those exposed to anti-TNFs compared to those who were not exposed. You can see that the risk ratio is basically 1 crossing 1 in terms of the confidence interval. And moreover, they found that anti-TNFs were not associated with worse tumor evolution, recurrence, or survival. And then when they did a subgroup analysis in terms of melanoma, there was no poorer survival. And there was no increased risk of recurrent NMSC or breast cancer. So I think this speaks to what we were saying, that the signal for anti-TNFs with melanoma seems to be less concerning now compared to a few years ago. So they recommend that anti-TNFs may be used in patients who have IBD with a previous or current cancer. And however, they do admit that, as I say, data on individual cancer types is quite limited. They do suggest that this is a situation where it has to be managed on a case-by-case basis in an MDT settings, including all of those specialists, and I think co-opting the patient. And then you have to consider the current and recent IBD activity, consider if there are alternative options. And then this guideline does not discuss when to restart a treatment should you choose to stop treatment. So, but I found another ECHO guideline, which was published last year. This is the one on cycling of biologic therapies, and they give different scenarios in patients who are pregnant, etc., etc. And here again, that ECHO guideline says that this would have to be done on a case-by-case basis. So there's a little bit of the alignment between this guideline and the cycling of biologics guideline from ECHO. What about the other small molecules? I mean, so ustekinumab and then Vido and the JAK inhibitors, again, 100% consensus. With respect to past malignancy, there doesn't seem to be any increased risk of cancer recurrence or new cancer with Vido or ustekinumab. However, there was insufficient evidence to make recommendations for the JAK inhibitors. And then in terms of a current malignancy, there's no data. And so they don't make any recommendation at all, other than to say that the decisions should be made on a case-by-case basis in an MDT setting, again, considering the patient as a whole, so patient factors, tumor factors, and alternative treatment options. So I'm trying to just summarize here the things that you would consider when you're managing an IBD patient with either past or current cancer. And I think you have to consider the factors of the cancer itself, the type, the stage, the time since diagnosis, the recurrence risk, and then systemic cancer therapy. You have to consider the IBD, disease activity, recent and current, the IBD phenotype, and then the therapies that the patient has been on now and previously. And then, as I say, importantly, you really have to consider patient perceptions, their fears, what they would prefer, and of course, you have to consider comorbidities. So it's not easy. I think it's a difficult it's difficult to manage these patients, and I think it really warrants a discussion with colleagues. I think that even if you are in private practice, it will be difficult to sort of make this decision on your own. You do have to engage the oncologist at least. So it's just to note that in patients with a past malignancy, the treatments that are considered to be safe and sort of not harming or harmful are 5 aminosalicylates, nutritional therapies in the right setting, mainly in the pediatric population, but also in the adult setting, and then local steroids are generally safe. But if you have a patient who's got a severe flare, then you can use systemic steroids. They do suggest methotrexate, as I said, for a slightly better profile. And then anti-TNFs can be used. So in this guideline, you can use anti-TNFs with caution, or you can consider surgery. And then after the cancer therapy, you need to decide the immunosuppressant based on the type of cancer and all those other factors that are stated. Obviously, naturally, if the patient has had these types of cancer, so lymphoma, leukemia, non-melanoma skin cancer, urinary tract cancer, you want to avoid the therapy. So I think the general message is that in patients with active cancer and with these cancers in the past, you really want to try and avoid thiopurines if you can. And then for melanoma, here they still say anti-TNF. This is from the old guideline. As I say, the current guideline didn't really have this guide. So from the old guideline, I think you have to consider melanoma, even though we are saying that it may be safe. But on an individual case-by-case patient basis, I think you'd have to be quite brave, I think, to persist with the anti-TNFs in a patient with melanoma, if there are other options for therapy, as was shown in the case presentation. So the current guideline didn't give this algorithm. This is an algorithm that I designed from 3 papers. The one was the old guideline in 2015, and then I found 2 additional papers, and I've just tried to consolidate what I've said, and hopefully this is not going to be confusing, because the current guideline actually doesn't really give guidance. It just says you need to consider IBD activity and all of that, but it doesn't tell you what to do in a patient who's got active IBD, etc. So I'm happy to take questions or criticisms on this, because it's the way I try to think about what you need to do. So if you're dealing with a patient who's got IBD and past malignancy, I think you need to consider whether the cancer is in remission for more than 2 years or not. If it is, then you need to consider whether there's a high risk of relapse based on what I've shown you. If there isn't, you need to consider if the IBD is currently active. And if it is not, then you can go for best symptomatic therapy. So this is really 5-SA, enteral nutrition, maybe local steroids if required. However, in a patient who has been in remission for more than 2 years, if you think there's a high risk of relapse, then you really need to consult the oncologist. Again, you can start with the 5-SA, enteral nutrition, perhaps consider surgery early. The current guideline does say that you can use thiopurines with caution, but you need to have enhanced monitoring both for the cancer as well as for the thiopurines. If the patient responds, that's fantastic, so we continue. However, if the patient does not respond or the IBD is active, then you really need to use therapies that are going to be effective for the IBD. So in this case, then you're going to do oral steroids or intravenous as is required. And then here they say you can consider second-line therapies. So the anti-TNFs, Vido and Uster. Remember, this is a patient with past history. And the guideline have said that you can use with caution on a case-by-case basis. As I've said, for methotrexate, if you're using combo, methotrexate is better than thiopurines. And then you have to consider the patient's concerns in all of this. If the patient has not been in remission for more than 2 years, you consider if the IBD is active. If it's not, again, you give the least toxic therapy and you continue your cancer surveillance. But if the IBD is active, then you're going to go the same route as that of a patient who had a high risk of relapse. And then in terms of managing a patient with current cancer, I think it's important to remember that remission of the IBD can be induced by treatment for the cancer. Because, you know, they are all immunosuppressive therapy and they might have similar mechanisms of action. So in this case, you need to consider whether the treatment for the cancer may actually also treat the IBD. And then if the IBD is not well controlled despite the chemotherapy, then you need to consider the IBD-specific therapies, first considering the 5-SA, steroids, and then anti-TNFs as a second-line therapy. So again, I've tried to do an algorithm, which I think makes sense to me, but sometimes I'm not so sure. But basically what you need to do is think about this. If the patient is currently on cytotoxic therapy and they are responding in terms of their IBD to the cytotoxic therapy, then you continue and you monitor the patient. But if the patient is not responding to the cytotoxic, so if the treatment for the cancer is not also helping the IBD, then you're going to start with steroids, and then your second line can be anti-TNFs. In this situation, because of the current malignancy, you want to avoid thiopurines. Whereas in patients with past malignancy, you could give thiopurines while monitoring carefully. If the patient is not on cytotoxic therapy, but the IBD is active, sorry, the IBD is not active, again, you can start with first line sort of safe therapy. If that doesn't work, you can give biologics. If you need to consider the other molecules, then this has to be on a case-by-case basis. And again, you need to avoid thiopurines. If the IBD is active, you have to give steroids. So here you give 5-SA and enteral nutrition or local steroids. But if the IBD is active, of course, you have to induce a remission with steroids. You can give anti-TNF if the flare is severe. Here they do warn that, you know, despite what we are saying about slightly safer signal for melanoma, really in the case of melanoma, it would be difficult to carry on with the anti-TNFs. And then if you're going to consider the other therapies, again, this needs to be on a case-by-case basis. So just to try and summarize what I've said, in case of caused confusion, this guideline compared to the previous guideline says that no thiopurines if the patient has got current cancer. However, you can use it with caution in patients with a previous history of cancer. No data for methotrexate or the JAK inhibitors. For anti-TNFs, in a patient who's had past cancer, you can use them. And even in patients who've got current cancer, you can use them, maybe not for melanoma. In terms of ustekinumab and the vedolizumab, if the patient has had past cancer with IBD, you can use them, although the data is limited. But in terms of the current cancer, there's absolutely no data, and the recommendation does not commit itself to anything in this situation. Strangely, in this guideline, they don't say anything about the calcineurin inhibitors. This was mentioned in the previous guideline of 2015, where they said you needed to stop those. In this guideline, there's absolutely no mention of this. So I'm not sure what one does about these. But again, I suspect that most people have moved away from using these agents. So I hope I've shown you that IBD per se, I mean, I think we all know this, is a risk factor for increased risk of malignancy. We know that the therapies for IBD are also a risk for malignancy. I think due to the complexities of managing this patient and the multiple factors that need to be considered, MDT management is really mandatory. I would say both for patients with IBD with previous as well as current cancer. And I think then the decision really still needs to be made on a case-by-case basis, taking into account the patient, their history, their family history, the other factors that I've spoken about, their previous response to medication, etc. And I think that the only thing that was clear for me from this guideline was not to use thiopurines if a patient has got current ongoing malignancy, but that if you need to use anti-TNFs, they are safe. I would just add here the proviso that maybe not for melanoma. I think we need to wait for more data for the melanoma story to be conclusively settled. And I think what we're suffering from in the IBD world, we're always lagging behind the rheumatologists and the other specialists, is that we really don't have enough data. And I think we just have to wait this out. And hopefully in the next 4 to 5 years, we may have guidelines that are maybe a little bit clearer, especially with respect to the newer agents. That's all I have. Happy to take questions. Thank you.
Thanks, Mash. That was probably the best presentation I've ever heard on the subject, I have to say. It's an impossible subject, and you did an outstanding. So, yeah, it was incredible. So, I mean, I think just, you know, not a specific question, but just the take-home message I got from your talk was that there really probably is no one size that fits all, because we know it's very impractical to set timelines. You know, you got a patient with severe IBD, you have to treat them, you know, so you're often stuck between a rock and a hard place. Would you like to comment on, you know, the risk of lymphoma and non-melanoma skin cancer with thiopurines in terms of, does that risk disappear with time, or is that risk always there when you stop drugs?
No. The good news is that with thiopurines, the risk does actually regress. So, I mean, I think if you find an elderly patient who's been on AZA forever, excuse me, it's still worth stopping the therapy. Yeah, there is a reversal.
Yeah, no, absolutely. So that is one good thing. There are no questions on the chat. Chris, do you have any words of wisdom or perhaps a complex case that you've struggled with?
Sorry, I'm actually mobile. No, excellent. As I said, yeah, Mashiko, excellent presentation and very complex. Look, we do see these not too infrequently, but luckily I've got a WhatsApp with Jill. She's my echo guideline. But no, I think the big thing for me here was the continued use of anti-TNFs. which is a big surprise to me. But no comments, further comments, and thank you.
Vidi's raised his hand. Vidi, do you want to unmute?
Hi, sorry, I actually joined in a bit late, other things to do. I just wanted, and maybe it was already mentioned earlier, what exactly is the role of EBV serology in IBD patients who obviously are planning to start AZA on? Should we be doing EBV serology? If we do EBV serology, whether it's positive, like negative, what exactly are we supposed to do with this result?
Jill, do you want to answer that, or you want me to do it?
Yeah, no, I'm happy to answer that. Okay, so EBV is almost ubiquitous. So we do it routinely, and I think it should be done on everybody who has starts on a thiopurine. If it's positive, it's irrelevant. Okay, if it's negative, that is where the important aspect is, because if it's negative and you start patients on a thiopurine, they have a chance of having a primary EBV infection, which can, be rapidly progressive and can be fatal. So thiopurine should really be avoided if possible in EBV negative patients, particularly in young males where that risk seems to be higher. So we do take it routinely, and we don't give it in EBV negative patients. EBD positive, well, everybody's EBD positive. Does that answer that question? Okay. Wayne, I see you've got your hand up.
Good afternoon, everyone, and thank you very much, Mashiko and John, for excellent talks on a topic which I think it's something that most of us deal with from time to time. I've got the latest patient I've seen like this. The reply from the dermatologist came back saying that he resected a basal cell carcinoma. It's a UC patient of mine, long-standing, and he's all spends a lot of time in the sun with his employment. And he then has a number of these solar keratoses, which in the dermatologist's reply, he makes a point that he's concerned about the azathioprine. So he's well in remission, quiescent disease. I've stopped the azathioprine. But my question is about solar keratoses and pre-malignant lesions, which all these articles are not very clear on. Yeah. I've taken the safe side and stopped the azathioprine. Your comments on that? Thanks.
Wayne, I think it's reasonable to stop because, as you correctly point out, the guidelines really don't say about these preneoplastic lesions. And you could argue that, well, if the patient is having screening and these BCCs are removed, then, maybe the risk is not that high. But I mean, in South Africa, if it's a Caucasian patient and with the UV exposure, and as you say, the occupational hazard, I mean, I think it would be difficult to persist with azathioprine in somebody like that. So I agree with you that I would change the therapy and just keep monitoring the patient and their yearly skin surveillance with the dermatologist.
Perfect. Thanks. Thanks, Michelle.
Other questions? So just an interesting observation, Mash, that you may want to comment on, but obviously the best therapy for a malignant melanoma is ipilimumab, which is one of the immune checkpoint inhibitors, which the most dreaded side effect of that, as you've alluded to, is a colitis, which can look a lot like acute severe ulcerative colitis, and the treatment is infliximab. So it's a little bit of a paradigm there.
It is. I mean, sometimes they say you can get away with the steroids and not have to withdraw the checkpoint inhibitor. But in some cases, you actually do have to. And as you say, then you need an anti-TNF.
Yeah, absolutely.
It's complicated.
It's very complicated. The whole topic fills me with dread, to be honest. And
For
as
me,
you said,
the point was that I actually found this guideline maybe not as clear as the 2015 one.
Absolutely. I found this guideline very, very, very vague. And, looking at it, if I have a patient in front of me and I had this guideline, I wouldn't be any closer to knowing what to do, to be perfectly honest. So I'm going to use your algorithm because I like it better.
Well, I hope there aren't any obvious contradictions. I had to read because it was time to put the three articles together to something that makes sense. I'll review it again.
It looked good to the naked eye, I must say. James, lovely to see you.
Hi, Angela. Thanks. Wonderful presentations. Thanks very much indeed. You just take us back to table view with a golden retrospectoscope. That lady did the same thing 3 times, almost 4 times over. And surgeons in those years convinced us that surgery was definitive. The problem has been dealt with and doesn't exist anymore. She demonstrated that it certainly did exist. How would you have managed her given your present state of knowledge? How should she be managed, or should she have been managed?
I actually think she was managed pretty much as with my specific state of knowledge. So with her surgery, she had a limited terminal ileum and cecal resection. She was a non-smoker, and based on that, a watch and wait and see attitude is entirely appropriate, because those patients very often can get away with 10 years of remission without actually needing therapy. So if I have a patient like that, in fact, I would probably recommend to them that they consider the surgical option upfront rather than going for drug therapy, provided they're non-smokers. The second one she was started on azathioprine afterwards, which would be our current practice. The only difference from then and now is that patients should have a colonoscopy done at 6 months to see if there's post-operative recurrence and treatment escalated. The methotrexate, yeah, also not a bad option, but that had to be stopped. So ultimately, at the end of the day, the problem was that she kept on disappearing off after her surgeries. So if she'd actually come and been followed up more closely, we would have certainly escalated therapy a lot faster. So it was a bit tricky with these long gaps in between, and then only presenting already when there was small bowel obstruction.
Thanks very much.
So, Joel, if you respond to Vido, are we going to do a fourth surgical resection?
Well, I'm just hoping she hasn't been there since February when I pulled the notes. So I hope she hasn't done a runner again. Please no. But I mean, the surgery is starting to get tricky, and there haven't been huge resections, but she's getting to that point where she's going to run into either a major surgical complication or she's going to end up having a short bowel syndrome. So hopefully she's just maybe been on holiday or something, and she's going to be up here soon. And then we'll take it one step at a time. If she fails Vido, then I think we'd be forced to use something like ustekinumab, or we don't have upadacitinib available yet in South Africa, but that would be another option if it was available. But yeah, hopefully she will reappear and we can see how she responds to the Vido.
Yeah.
Okay, so I think we're out of time. So thanks very much, Mash. And my thanks, of course, to iEcho University of New Mexico and the iEcho India team. Thanks, of course, to the GI Foundation, and as always to Chris. And of course, thanks to the sponsors. We could never do these sorts of things without their help. The recordings are available on the Gastro Foundation website. And just to mention that next week's iEcho is pathology. So thanks everybody for tuning in, and we'll see you next time, and have a lovely evening. Cheers.
Thanks, Joel.
Cheers, Mash. See you.